Thank you. Good morning, everybody. And I want to thank you for the opportunity to speak today. And I also need to thank Arjun for doing the slides, which I happily stole last night when I found out about this 13 hours ago. So I want to talk about technology and its impact on how we're delivering care for CNS tumors. And as you'll see through the talk, that this is really an international effort. But I do want to talk about how Sunnybrook is collaborating with our international colleagues to try to move this field forward. So CNS at Sunnybrook is an army. It's comprised of both the healthcare physicians, allied health, support fellows, nursing, nurse practitioners, researchers, and it's truly within this environment that we're able to move forward both our clinical agenda as well as the research program. And really we've tried to collaborate amongst multiple levels of investigators, whether it be through drug trials, imaging-based science through the Sunnybrook Research Institute, education sessions, and really the whole central goal is to promote patient care. And with this model, certainly we've seen an increase in our workload, that the numbers of patients treated in 2006 versus 2015 have doubled. And with that, so is the size of our group, that we've gone from 2 CNS radiation oncologists to now, starting next month, our 5th. And so there's been an exponential growth with respect to what we're able to offer patients and how we're able to harness each individual's research goals to promote the agenda. And we've had a long-standing tradition of drug trials. And this is just a short list of some of the international studies that we've been involved with. And this is both local, national, and international trials. And CE6, which has really been led by ourselves as well as the team at Princess Margaret, published one of the landmark papers recently with respect to the treatment of patients over 70 with glioblastoma. And it's really been this collaborative effort which has moved forward that component of our research program. And I'm proud to say that we are the first Canadian site to open a recent phase 3 study with collaboration with the ERTC evaluating a novel agent, and we enrolled our first patient last week. But how do we harness drug therapy and the tradition we've had with that aspect of treatment with emerging technologies? And I want to talk about our cancer ablative, or CAT program, which is the concept of using localized high-dose radiotherapy to provide durable local control and ultimately improve patient survival. And I'm going to focus on 3 components within the CNS department: the gamma knife icon, advanced MRI imaging, and ultimately to the MR linear accelerator. Brain SRS is high-dose treatment of metastases from other sites in the body. And this has evolved over the last 30 years to the current state where we're using the gamma knife icon system. One thing to note, this is not for gliomas. And this is a question that we're commonly asked, and that is not appropriate for this treatment modality. This is really designed for metastatic disease or for benign tumors which are easily localizable. So let's start with a case. And this would be a very common presentation that we would get. And this is a 50-year-old woman who was diagnosed 6 years ago with breast cancer. She was treated with standard therapy and was clinically well until she developed seizures. MRI imaging revealed 2 brain metastases. Other sites of disease not detected. So she was opted to be treated with radiosurgery. High-dose focal radiotherapy was delivered, and we can see 6 years later, so we're now 12 years post-original diagnosis, her disease is still controlled, no evidence of disease, with no ramifications or side effects from her therapy. So why do we like this? Why is this technology important? When you look over the history of intracranial radiation, it started with whole brain radiotherapy. And this was the workhorse treatment for 30, 40, 50 years. And it is still highly appropriate today in selected patients. However, with the development of radiosurgery technique, we can deliver focal doses to a much higher degree. So you get the benefit of dose escalation to the tumors, but more importantly, you're protecting the normal brain from the negative effects of radiation. And our program has certainly evolved over the years. It has gone from very rudimentary treatments to more refined image-guided therapy, to patients who required invasive frames. So if you look on the right, the patient who had to have pins screwed into her skull in order to have her treatment delivered, now towards a highly image-guided, non-invasive approach. And we looked at this. We looked at why is one immobilization system better than the other. And until recently, having invasive frames was still more accurate. We require high precision with the delivery of this therapy, and we need sub-millimeter precision, and truly, we are only achieving that with the frame. But then came along this, and this is the newest advance in intracranial radiosurgery. It's called the Gamma Knife Icon system, and it's a combination of imaging at the time of treatment with infrared sensors for evaluating patient position. And we've done the work, and we've looked at the verification of this. And using a mask, as opposed to having pins placed in people's skull, we're able to achieve the same degree of precision. And what this has allowed us to do is be much more patient-centric with our care, increase our workflow, and become more robust with respect to treating multiple metastases, which were impossible before with the invasive frame. Why is this important? I come back to protecting the normal brain. And early, we started looking at the impact of whole brain radiation versus delivery of radiosurgery. And multiple trials have been done looking at this, all showing that there is no detriment in giving radiosurgery as opposed to traditional whole brain radiation. But what was interesting was in select cases, we started to see that whole brain radiation may actually negatively impact patients, not only cognition, but survival. So we're grateful to our colleagues from the Alliance Group in the United States who looked at this, and they looked at the effect of radiosurgery versus whole brain radiation, focusing on cognition. And what did they find? They found indeed what we had thought, that whole brain radiation does reduce cognition in multiple domains, both in terms of verbal recall, concentration, and overall cognitive ability. Now, when you look at the graph on the right, it shows that there is increased control of the brain when you do whole brain radiation plus radiosurgery. So what's interesting about this data is despite there being no impact on survival, if you do one versus the other, you're going to live the same amount of time. And despite the fact that if we give whole brain radiation, it does treat microscopic disease that we can't see, the outcomes cognitively are worse. So it's not the tumor, it's actually the treatment. And given this finding, we've now adopted an approach where we will treat people upfront with radiosurgery when appropriate, and we will continue to follow them with serial MRI surveillance. And should there be any progression of disease, we will continue to use radiosurgery. And this has been our paradigm, and really it's designed to, again, maximize control, but decrease the side effects. And we know that there is a mechanism for harm. Very good data has been presented looking at structures within the brain that are responsible for cognition. And this trial looked at the hippocampus and its role in memory formation and the effect of radiation on that structure. And based upon this, strategies have been developed, again, to mitigate the effect of harm. Hippocampal sparing whole brain radiation, where advanced planning is done to protect that structure, has been proposed. Using drugs during radiation as radiation-protected agents have been utilized. But really, from our perspective, it's the best way to spare the hippocampus is not to treat the hippocampus. And again, this furthers our opinion that radiosurgery is the appropriate choice, and it shouldn't be down to number. There used to be a threshold that if you had 4 or less, radiosurgery was appropriate. Anything more than that, we really needed to deliver whole brain radiation. And we've been challenging that idea. And really, it should be from the technical perspective. Is it technically achievable to treat multiple metastases in the right patient? And so we're pushing it. This is a patient who's treated with 29 sessions. This was with the invasive frame. And I can say that we've been, again, pushing it even further with having the Gamma Knife icon system, where my personal record right now is 47. And that was done over a period of 5 days. So patients can have a few treated at a time in a much more convenient fashion for themselves, as opposed to being treated for hours at a time. And what were the outcomes? When you look at the dose to the whole brain, a very classic standard radiation dose whole brain would be 20 gray and 5 fractions. So by treating even 30 targets with radiosurgery, the mean dose to the brain was only 3 gray, less than 1 dose of whole brain radiation. And again, this is, for us, proof of principle of this technique. The Gamma Knife does provide benefits over other treatment technologies, which is why we've adopted it. And we're about to open a trial where we're looking at the role of radiosurgery and whole brain radiotherapy for multiple brain metastases, because we want to prove what we currently believe. It's not enough to say, this is our opinion. We need to provide the facts and the science behind it. And so, led by my colleague, Dr. Eric Singh, we're hoping to begin later this year, early in 2019, a trial to open up where we will be randomizing patients to radiosurgery versus whole brain plus radiosurgery, and primary endpoint, again, is going to be cognitive issues. But we don't want to be just local. We want to move further. And so Arjun and my colleague James Perry from Neuro-Oncology are part of the provincial strategy trying to harmonize treatments within the province to ensure that we've got quality of care for patients closer to home. It's not appropriate for this just to be delivered in Toronto. We need this to be available in every center so that all patients with these malignancies have access to care. And it's really based upon this guideline that education sessions, quality assurance protocols have been developed so that care can be delivered closer to home. And this shows how trends have happened within our center. 2005, hands down, the predominant number of cases were being treated with whole brain radiotherapy. But look at the shift around 2010, what has happened. That the radiosurgery cases have absolutely skyrocketed. And that's a reflection, again, of our belief, but also the referrals that we've been getting across the province from physicians as well as patients who have been advocating for this treatment. But it's not just brain metastases that we can treat. We're looking at developing a functional program as well, so treating AVMs or malformations of the vasculature in the brain. We've been treating pituitary tumors, and in fact, there's been now some cases of phallotomies for patients who have psychiatric disorders. And so this technology is branching out from the malignant tumor to the benign and now for other functional indications. So it's a very exciting time for us. But we can't do this without advanced imaging. And recently we got advanced MRI imaging as part of our workflow at the Odette. And what this has allowed us to do, again, is better visualization of the tumors, better understanding of the site and location, but also to provide us functional information. And what we're looking at is, can we use imaging to predict responsive therapy? And this has been a huge area of interest and a large collaboration with the Sunnybrook Research Institute. CEST imaging, we like to call it MRI-based PET scans. And it is looking at functional markers in tumor and normal brain. And we've had a robust area of research and now published looking at response of brain metastases to radiosurgery using this imaging technique. We've also been able to use it to determine whether post-treatment is radiation-induced change necrosis versus progressive tumor. And this is vitally important as we're looking at patients after treatment, trying to understand what to do next with these MRI changes, because the implications may be enormous, whether it's more radiation, more surgery, or if we can predict that this is radiation effect which will resolve over time and we can just watch them. Based on that work, we pushed into the glioma, and we reported last year using a technique called magnetization transfer, again, advanced MRI imaging, Well, during treatment for glioblastoma, we've been able to predict patients who are going to respond to therapy at day 10 of their treatment. Now, this needs to be validated in a larger cohort, and we're currently underway on trials of that. But again, imagine the power of being able to predict response of patients 2 weeks in treatment, and whether we need to be adapting radiation planning, adapting entire treatment protocol, or continuing on its way. Again, in the same cohort, using that CEST technology that I just discussed, we're looking at responsive treatment with glioblastoma. So it's not just enough to be able to target the tumors, we have to be able to understand it and what happens as we're giving treatment. One of our neuroradiology colleagues has published a technique called QBOLD, where using advanced MRI imaging, we're able to predict the areas of high oxygen concentration and blood flow within tumors. And what we want to look at is, can we harness this imaging technique again to tailor radiation? Perhaps we need to be giving more radiation dose to areas where we would predict to have more resistance. And of note, this work was funded in part by the Brain Tumor Foundation of Canada. So it's great thanks to them for that. But what's next? And we've been focusing on traditional ways of treatment. And this is what we think is the future. Radiation for decades has been delivered with something called the linear accelerator, or LINAC. And there has been evolution with respect to how we're able to image patients on treatment. It used to be plain X-ray films, and we would use that to localize tumors. And so on the left, you can see the level of detail that we used to have. Currently, right now, the evolution has been to put a CT scanner on the unit. And that has provided dramatic improvements in the ability to target and localize treatments. However, we believe that the future is MRI. And this is the Electa Unity. And this is the first in Canada MR LINAC, which has been based part on an international consortium. And this has been an engineering feat. Nobody thought that you could deliver X-rays through a magnetic field before. And this has really been a tour de force of engineering to allow this to happen. And this was conceived years ago, and a global consortium was established to develop not only the technology, but the clinical protocols of this. And we were very proud to be one of the founding members of the MR LINAC Consortium. And each group has been tasked a very specific site to push the clinical and research agenda. And Sunnybrook is the CNS group. So what had to happen? First, again, we had to understand how the radiation can be delivered in this field. And our physics department has been instrumental in understanding what happens with these beams and what happens with the radiation dose to patients in a magnetic field. And with that, we've been able to model. And again, my colleague, Dr. Seng, led this as part of his work, both at Sunnybrook as well as in Utrecht in the Netherlands, to model what would happen to patients treated in the MR LINAC. And the modeling all shows that it can be delivered safely and highly effectively. So we had to develop now an entire brain strategy. And our end goal is to develop a multinational clinical trial evaluating this technique for glioblastoma. But there's a lot of work that has to be done. And the first thing was getting doctors to agree on something. And that is, what is the true target? What are we treating? What do we need to treat? And founding members of the consortium all met, and they had a 2-day session of education, training, and then contouring sessions where guidelines were established to set the stage for the next clinical trials. And you can see there was wide variation of what people are doing across the globe. And if you're going to do research, you need to make sure that everyone's on the same page. And so this has now been established and will be published as part of the international guidelines shortly. But we also need to understand what happens to these tumors during treatment. And this has been work that I've been leading, looking at MRI during treatment to understand what happens to these tumors. And importantly, we need to be able to do MRI without giving IV contrast every day, because that's not possible. And so we've been looking at novel MRI techniques, trying to understand what happens to tumors during therapy. So we need to have our eyes open as we move forward, because this is what can happen. And this is a real case of what we thought we were treating versus what was happening in the brain. So what are we doing with this? This is all early stages, and this needs to be validated. But as we've seen evolution of changes of the tumor during therapy, we've been adapting and changing our plans to ensure that we're encompassing all sites of disease. We've been able to predict patients who are going to run into trouble on therapy. And this was my patient, who had an operation, started on treatment, on imaging. Even though she was asymptomatic, we started noticing evolution within her tumor. And at day 20, even though she continued to be asymptomatic, we predicted problems. We got her in contact with neurosurgery, and she became symptomatic just before she got to the operating room for re-resection. So again, can we tailor care individually with imaging? I think the answer is yes. Something as simple as steroids. Anyone who's ever been on steroids knows that long-term use can be quite damaging. Can we use imaging during treatment to decrease steroid doses in an educated fashion as opposed to guessing? And we believe the answer to that is yes as well. And this is going to be subject to further trial. So we're moving forward. We're getting ready for human trials shortly. And these are images from the first in-brain scan done at one of our sister sites in Wisconsin. And as you can see, these images are certainly not as pretty as what we're used to seeing. And so there's a lot of work to be done, and this is what's still to come from our research group. So where can we go? We can evaluate changes in the brain. We can detect disease which is developed elsewhere in the brain. We can reduce steroid doses, but more importantly, can we biologically adapt therapy? And that's the holy grail of this, is can we use these images to personalize and accelerate care? So this is what it was. This was the MR magnet being dropped in, and again, they cut holes in the side of the hospital. We lived in a construction zone for a long time, but it's now in. And first-in-man treatment was reported last year, showing proof of principle, and this is our group. But there's more to come. And one area which is fascinating is the concept of the blood-brain barrier. We all know from drug trials that the blood-brain barrier is what keeps highly effective systemic therapy from entering the brain. And is there something that we can do to affect that, again, to improve systemic control of disease? And we're very fortunate to be working with a group at SRI and Clarevo, who is a world expert in focused ultrasound, and in particular MRI focused ultrasound. And this has been shown to be used in benign tumors. So reports of using focused ultrasound as an ablative, non-invasive technique for tremor. But we're hoping to harness this for much more than that. And this was the first patient on our trial of she had a grade 3 tumor where prior to an operation, she had focused ultrasound, chemotherapy delivered, focused ultrasound. At the time of operation, we were able to measure that by temporarily disrupting the blood-brain barrier, you can increase the concentration of highly effective drug in the brain. So this was patient 1, and we continue to move forward with this approach and this protocol, but it's going to move further. And Nir Lipsman, one of our neurosurgeons, has now started a trial where for patients after radiation and for the adjuvant temozolomide component of their therapy, they're getting focused ultrasound to see if by opening the blood-brain barrier, can we increase the dose of temozolomide actually getting to the tumor. But what's very exciting is where it can be used in other sites. Leptomeningeal disease, which is a dreaded complication of metastatic disease to the spine. This is an animal model, again, first demonstrated that we can open up the meninges in the spine. And can we use this technique to provide more active chemotherapy to this very difficult patient population? And what's very cool is now the merging of this with the MR-Linac. And my colleague, Dr. Trinata, just got an innovation grant where we will be putting, again, the first in the world, high-focus ultrasound microbubble couch on the MR-Linac to coordinate both radiation and high-focused ultrasound therapy. And this is an incredibly exciting area of research for us. And certainly we can't do this without awareness, without advocacy, without philanthropy. And we thank all of our partner colleagues, and certainly we thank the team at the Brain Tumor Foundation for patient support, patient advocacy, and also for their support of research. So things have changed dramatically over the last decade. And really our goal is, think globally, work locally. And it's with these collaborations that we hope to make real change. And we're really focused on improving the care for our patients, not only for the disease, but for their quality of life and functioning. And really, for GBM, one day we want to figure it out. And we want to be part of the cure. So I thank everyone who's here for, again, allowing me the opportunity to speak. And what a wonderful session. And is it a bad sign when you're hearing about someone donating tattoos and you've got tears welling up in your eyes? Like I sat there, just the group here and the spirit and what has been done, I think, is remarkable. Thank you.